All right. Well, good evening, and thank you for coming out tonight to learn a bit about PTSD. It's a condition that we hear a lot about, a lot of media attention on PTSD, a lot of movie depictions of PTSD, but it's a condition that there's a lot of information out there about, but not a whole lot of understanding of exactly what it is, what it looks like, and why it happens. So that's sort of my main purpose tonight, is to talk a little bit about the symptoms of PTSD, to talk about a model for understanding why PTSD happens and what happens in PTSD. And at the end, to talk briefly a little bit about effective treatments for PTSD. What you're not going to get tonight is 5 simple tips to manage PTSD, because PTSD doesn't work quite like that. And it's not quite so simple because there's a whole lot of variability in PTSD. So you can have 2 people, both who meet full diagnostic criteria for PTSD, that look very different in terms of symptom presentation, in terms of just how the PTSD is affecting them. So tonight isn't about tips to fix it. Tonight's about understanding it, which I think goes a long way in sort of demystifying the experience of PTSD. So we'll start with the notion of trauma and talk about what exactly we mean when we talk about trauma. So I tend to categorize trauma into 2 broad categories. The first is traumas related to accidents. So things like motor vehicle accidents. One of the most common causes of PTSD in North America is PTSD from motor vehicle accidents. There's industrial accidents, workplace accidents, natural disasters like tsunamis and earthquakes, and then rarer events. One that is notable that happens, that's fortunately doesn't occur too often, is actually waking up in surgery. And if you can imagine waking up in the middle of surgery, that can be something that would be extremely horrifying and a scary experience. So these are examples of accidental trauma. And then there's a second subcategory of traumas, or broad category of traumas, that I refer more to as interpersonal assault or interpersonal violence. So things like domestic violence or intimate partner abuse, physical assault, childhood abuse, either childhood physical abuse, childhood sexual abuse. Sexual assault, date rape, stranger assault, coercive sexual assaults, armed robbery, muggings, having a weapon pulled out against you, kidnapping, combat, both from the perspective of soldiers involved in combat, but also civilians involved in combat areas, and torture. So you can probably get a sense of why we tend to make a distinction between the 2 different types of trauma, because they're going to affect a person in different ways in terms of what a person takes away from the trauma experience. So, for example, in the accident traumas, what it highlights for a lot of people is the unpredictability and uncontrollability of life, the randomness of events. Those accidents aren't necessarily caused by anybody's willful behavior. They're just things that happen that you don't have any control over. So for a lot of people, that can bring up a lot of issues and a lot of things that sort of scary regarding lack of control in life. Whereas for these types of traumas, the interpersonal violence traumas, it brings up issues about the malevolence of people and human beings' capacity for evil, and how people could intentionally do something like that to someone else. So it brings up a lot of issues regarding trust, and compassion, and evil within other people. So talking about trauma, there's different ways that a person can be exposed to these different types of traumas. The most obvious is direct exposure to the events. So I'm in the motor vehicle accident. I am the bank teller who is held up at gunpoint. So I'm the one who's directly experiencing the traumatic event. I can directly witness the events happening to somebody else. So I'm there when that person was shot. I'm there when that person was physically assaulted, and I witnessed it. So it didn't happen to me, but I saw it happen to someone else. Trauma exposure can also involve indirect exposure through learning about the events happening to a close family member. So I learn about my child being killed in a motor vehicle accident and develop PTSD from something traumatic, something horrible happening to someone who is very close to me. And a fourth way of experiencing trauma is through repeated exposure to details of traumatic events happening to other people. Now, this isn't details of traumatic events happening to anybody who's necessarily close to me or anyone I know, but this is repeated exposure to traumatic events or details of traumatic events happening to others. And you'll often see this in police officers, in victim services workers, who are constantly exposed day after day after day to repeated horrific details of awful things that have happened to other people. And as one police officer once described it to me, it's sort of like death from 1,000 cuts. So it's that repetitive exposure to these traumatic details happening to other people. So there's a variety of different types of trauma that people can experience and a variety of different ways in which people can experience these traumatic events. But one thing I like to highlight is just because an event is traumatic to somebody doesn't mean it's trauma in the context of what we're going to be talking about tonight as trauma. So on one side of it, the majority of people who are exposed to these types of traumatic events don't have any ongoing difficulties from those events. So the majority of people who are involved in motor vehicle accidents don't have any ongoing difficulties following the motor vehicle accidents. But on the flip side of it, there are a lot of people who will experience events that they experience as traumatizing, but wouldn't be considered trauma in the context of what I'm talking about tonight. So things like divorce, or finding out that your spouse is having an affair on you. That can be extremely traumatizing to somebody, but it's not in the context of what I'll be talking about tonight in terms of trauma and PTSD. Equally so, bullying and workplace harassment. There's some research that actually shows that people who are victims of repeated sort of workplace harassment, workplace bullying, can experience a cluster of symptoms that look a lot like PTSD, but it's not PTSD, because the nature of the trauma isn't what we'd consider nature of trauma for PTSD. So what exactly is PTSD? Post-traumatic stress disorder is a collection of symptoms that occur in response to exposure to a single or multiple traumatic events. These symptoms, it's actually very common for people to experience a lot of these symptoms in the weeks that follow a traumatic event. But for PTSD, the symptoms have to persist for at least a month after the trauma. So technically speaking, you cannot have PTSD within the months after a traumatic event. It's something that happens at least a month after the traumatic event. So that's the whole post-traumatic stress disorder, something that happens after the fact. And after you would expect that the normal course of healing from a traumatic event would take place. In terms of prevalence, about 9% of the population at some point in their life will experience post-traumatic stress disorder. If you think about that number, that is a lot of people in the world who will be exposed to PTSD and will meet criteria for PTSD at some point in their life. Now, there's differential rates of PTSD depending on different types of trauma. So if you notice on this slide, a lot of the interpersonal types of trauma have higher rates of PTSD associated with them, whereas the accidental traumas, things like motor vehicle accidents or natural disasters, have lower rates of PTSD associated with them. Interesting thing to point out is even within sort of certain categories of trauma, like combat, you can see differential rates of PTSD. So for example, in Vietnam veterans, it was estimated that about 30% of Vietnam veterans suffered from PTSD. Now it's an estimate because PTSD actually didn't exist as a diagnosis until 1980. Part of the reason PTSD actually came to be a diagnosis was what people were seeing in veterans coming back from Vietnam. So it's an estimate that about 30% of Vietnam vets suffer from PTSD, whereas both Gulf Wars and Afghanistan, they're looking at about 13 to 14%. So it isn't just about being in combat. There's something about the nature of combat and the nature of the combat that you're exposed to that will heighten the risk of developing PTSD. Now, we don't have a lot of time to get into it, but you can just imagine and think about why it is that Vietnam veterans may have higher levels of PTSD than Gulf War and Afghan veterans. So it may have something to do with the nature of the combat that they were exposed to. It may also have to do with the sociocultural environment that the veterans were returning to after the wars. So Vietnam veterans came back to a very different society and very different environment than Afghanistan and Gulf War veterans. And so that may have had an impact on increasing the rates of PTSD in Vietnam vets. So the take-home message is not all trauma is created equal, and not all traumas are going to affect people in the same way. So in terms of symptom clusters in PTSD, PTSD is a combination of 4 clusters of symptoms. The first is what's referred to as re-experiencing symptoms. These are kind of your prototypical PTSD symptoms that you often see depicted in movies. These are the things like flashbacks, intrusive memories, intrusive thoughts. So some of these are re-experiencing symptoms, unwanted, recurrent, intrusive memories or thoughts about the traumatic event. So this isn't me ruminating on it or me intentionally thinking about it. This is me, I'm working away at my computer and a memory or an image of the grill of the truck comes into my mind and upsets me. These are thoughts that I don't want to have. These are memories I don't want to have, but they keep coming up regardless of whether or not I want them. Recurrent distressing dreams, nightmares about the traumatic event. Now, the nightmares can either be directly related to the traumatic event, so it can be a re-experiencing of the trauma itself, or they can be nightmares that are essentially thematically related to the trauma. So I'm in a car, I'm in a motor vehicle accident with my kids in the back seat. I was terrified at the time that they were seriously injured. Fortunately, they were okay, but I start having nightmares about bad things happening to them. So not necessarily them being involved in a motor vehicle accident, but them getting kidnapped, them being killed, those types of things. So themes related to the trauma, but not a direct recreation of the trauma itself. People can experience flashbacks, and people use the term flashbacks a lot. But I often find that what people are referring to when they refer to flashbacks is those intrusive memories or images of the trauma. When we talk about flashbacks, flashbacks are almost a sort of an altered sensory experience. So when people experience a flashback, they can experience something like, I actually smell gasoline. So it's not me remembering the smell of gasoline, it's in that moment I'm smelling gasoline after the motor vehicle, from the motor vehicle accident. These flashbacks can also go to an extreme where a person actually dissociates. So if they're in the office talking to me, they will no longer be in the office talking to me. They will be in the bunker on the battlefield with shells blowing off around them, and they're not aware of where they are. They're not conscious that they're actually in a safe place in an office. They perceive themselves as actually back in the danger zone in the trauma. And that can be to an extreme. And that can be a very scary experience for people because they don't know where they are. They don't know when they come to, they have a period of time where they just don't remember what happened. So this is very much of a dissociative experience for people as opposed to just a vivid recollection of the trauma itself. And finally, psychological distress or physiological reactivity when reminded of the trauma. So I hear screeching tires, it makes me really upset or anxious. I see an armed robbery depicted on TV, and I break down crying. One of the most memorable experiences I've had with this, I was assessing a client who had been locked in one of those industrial freezers, and he was accidentally locked in one of those, and he was terrified that he was going to die there, that nobody was going to find him and he was going to freeze. Well, as we were doing the assessment, the air conditioning in my office kicked in, and the cold air started blowing down on him, and he literally turned blue and began to shake because the memory or the trigger of the cold air being on him triggered that physiological response. It also triggered the anxiety in him. So all sorts of things can trigger people, can trigger memories of the traumatic event. Anniversaries are a big one as well that a lot of people often don't think about, but the anniversary of the trauma will often be a big trigger for a lot of people. Second cluster of symptoms relates to avoidance. And avoidance can take a couple of different forms. One is efforts to avoid any thoughts, feelings, or memories about the traumatic event. If the thoughts come into my head, I try and suppress them. I'll try and distract myself. I'll try to get my mind off of thinking about these events. Drugs and alcohol come in quite handy in this situation where a lot of people will rely on drugs and alcohol to help get their minds and get their thoughts off of the traumatic events, or at least help suppress those thoughts. Second form that avoidance takes is more behavioral avoidance. So avoidance of external reminders that bring up memories or thoughts about the event. So I'll avoid people, places, conversations. I'll avoid talking about it, avoid activities that remind me about it, avoid objects or situations. So we'll try to avoid anything that might remind me of the trauma. And we'll talk about how this leads to problems in PTSD and how this type of avoidance isn't entirely effective, at least certainly not in the long term. Third cluster of symptoms, and this is new in the most recent version of the DSM-5. This relates to negative alterations in the way a person feels and the way a person thinks about the trauma and the impact that the trauma has had on them, as well as the implications of the trauma on the world and other people. So this can take the form of being unable to remember important aspects of the traumatic event. Now, this isn't because I was knocked unconscious at the time of the trauma and I can't remember details of it, or I was intoxicated and that's why I can't remember details. This is more of a dissociative nature. So I've worked with a lot of sexual assault victims where they don't remember details of the sexual assault, but they can describe the ceiling tiles in tremendous detail, because at the time of the assault, they wanted to essentially get out of their bodies, get out of the experience of what they were experiencing, and they're focusing on something external to them. So they weren't processing anything that was happening inside of them or to them at the time. So when it comes to remember the trauma, they're not going to remember any of the details because they weren't actually processing any of the details at the time. Negative beliefs and expectations about oneself, the world, and others. So I often see people refer to themselves as seeing themselves as broken, seeing themselves as changed forever following the trauma in a negative way. Seeing others as untrustworthy. I can't trust other people. I can't trust men. Seeing the world as a dangerous place. That bad things happen and the world is random in a bad way. Distorted beliefs about the cause or the consequences of the traumatic event, which leads to either blaming myself or blaming other people. I should have done more to fight off my assailant. I should have fought them off harder. I shouldn't have been in that part of town at that time of night. It was an old person who was driving the vehicle that hit me. Old people shouldn't be driving. You can't trust old drivers at all. So these negative beliefs that stem from either thinking about the cause or the consequences of the traumatic event. Persistent negative emotional states. So people with PTSD can often experience persistent feelings of fear, anger, guilt, shame much of the time. So this isn't sort of passing feelings. These are kind of consistently there and sort of always there with me. Decreased interest or participation in significant activities. So a withdrawal from life, a withdrawal from activities they used to enjoy doing. So I'll no longer be playing hockey or avoid hiking or just withdraw from any of those activities because there's just no interest, desire, motivation to do those things. Detachment or estrangement from other people. Sort of the sense of, it's hard for me to connect with others. They don't really understand me, I don't really understand them. And this can be a really difficult symptom for a lot of people, especially people with spouses, people with children. After the traumatic event, they just feel that there's a disconnect and that they can't connect with their spouse. They can't connect with their children, and they wonder what's happened to them. Why is that the case? They don't really necessarily note or know that it's related to the PTSD. They just feel that they've been changed and they'll never be able to relate to others. And one of the last of these negative alterations in mood and thinking relates to emotional numbing. Just a general state of feeling emotionally numb, being unable to experience feelings like happiness, joy, satisfaction. I've had clients describe it to me as, I feel robotic. I go through the motions of my life and I kind of pretend like I'm enjoying things for the sake of other people, but I'm actually not feeling any sense of enjoyment at all. And that may be part of the decreased participation in significant activities as well. There's just no sense of enjoyment or happiness in those activities. And the last of the 4 clusters of PTSD symptoms relate to hyperarousal symptoms. Essentially, for people with PTSD, they're kind of in this constant state of hyperarousal, constant state of being hyper alert for danger or for threat. So this can lead to symptoms like irritability or anger, verbal or physical aggression towards other people, towards objects. This can lead to a lot of problems in interpersonal relationships, friendships, close family relationships. Reckless or self-destructive behavior. Things like dangerous driving or excessive alcohol or drug use, self-injurious behavior, cutting, burning, those types of things, even suicidal behavior. Essentially, I've had a lot of people with PTSD say to me, I don't care if I die. It's just, I don't feel I'm going to live that long anyway, so what's the point? Hypervigilance to danger or threat. Essentially, people with PTSD can get into situations where they're kind of constantly scanning their environment for any signs of danger or threat. I've had a number of clients with PTSD, and if I were to walk into a restaurant with them, I would know exactly where they would sit. They would sit with their back to the wall, facing the entrances and exits, paying attention to everyone who's entering and leaving that place. Constantly scanning, constantly aware of any signs of danger or threat. This is one of the reasons why a lot of people with PTSD do not like being in crowds. It is hard to pay attention to everything that's going on when there's lots of people or lots of things going on around you. An exaggerated startle response. People with PTSD often can startle quite easily. Loud noises, people coming up from behind when they weren't expecting it. Some less than sensitive friends may find this kind of funny. Let's see if we can scare them by, hey! And person with PTSD freaks out and gets really upset, and people find that funny. I once had a client describe he came home one day and it was a surprise birthday party, and everybody jumped out and yelled, "Surprise!" He tore out of the house and ran into the bushes and hid there because he was so terrified and he'd been so startled by what had happened. Concentration problems, difficulty focusing, difficulty reading. If I'm watching a movie, it's hard to keep track of what's going on with the plot of the movie because it's hard for me to maintain my focus on things that I'm paying attention to. And finally, sleep disturbance. Difficulties falling asleep, difficulties staying asleep, very light sleep, so even little noises will wake me up. Nightmares as well often contribute to sleep disturbance. So not everybody with PTSD experiences every single one of these symptoms. For PTSD, you need just one re-experiencing symptoms, you need one avoidance symptoms, you need two negative alterations in cognitions and mood, and you need two hyperarousal symptoms. So if you think about all the different computations and permutations, you can have people with PTSD that don't share any of the same symptoms, but meet criteria for the same disorder. So there's high level of variability in terms of how people experience their PTSD, not even taking into consideration the differences in the different types of traumas that we talked about earlier. Now, in terms of associated problems with PTSD, you can imagine that someone suffering from some of those symptoms, it's going to affect a lot of different areas in their life. People with PTSD have high rates of other psychological problems: depression, generalized anxiety disorder, panic disorder, and substance use disorders. They share a lot of the same symptoms with those conditions. Bet this isn't too difficult to understand. Impairments in social relationships, through irritability, through that sense of detachment or estrangement from other people, the withdrawal from previously enjoyed activities. There's a lot of different ways in which PTSD can negatively affect interpersonal relationships and social relationships. Limitations in mobility. Most obvious example is in PTSD resulting from motor vehicle accidents, where people are afraid or nervous to drive. So they'll limit where they drive, they'll limit when they drive. They often have a certain radius of mobility just around their house or in areas that they know where they will drive to, but they won't drive outside of those areas, which can be extremely limiting for someone in terms of social activities, recreational activities, just feeling free and moving around. And then there's absenteeism and presenteeism, both in work and social life. So absenteeism at work, well, it's just not showing up to work. I didn't sleep very well the night before, so I don't go to work. Social life, I don't really want to go to that concert because I don't want to be around all of those people. I'm not really that interested in doing those things. I'd just rather be alone. So being absent in social life. Now, presenteeism, a lot of people know what absenteeism is, but a lot of people have never heard of presenteeism. Presenteeism is essentially being present, but really actually not being present. So I'm at work, but I've just spent the last 2 hours staring at my computer screen, and I haven't done anything because I can't really focus. Or presenteeism in social life. I've been playing with my kids, and I'm playing the games with them, but I'm going through the motions, and I'm not actually there, and they can tell that I'm not actually there. So you can tell when someone's physically present, but isn't actually present. So that's that presenteeism. So it can affect both work and social life. So in terms of that's what PTSD is, that's the symptoms of PTSD. I want to talk about a model for which you can understand how PTSD works. And this is a model that I use with all my clients because I think it's really important to understand how PTSD works, because if you don't understand how PTSD works, some of the treatment that I'm going to be talking about later makes absolutely no sense. So with PTSD, I like to draw a distinction between a person feeling safe versus a person being safe. We often think of the two as the same. When I feel safe, I am generally safe. But that's not always the case. So I want to introduce you to Phil. Phil's a happy-go-lucky kind of guy. He's off to school with his binder and his little bow tie. It's a beautiful sunny day. He's loving life, feeling totally at peace, totally calm, totally at ease. Phil feels safe. Now, unbeknownst to Phil, he's walking underneath a high-rise building, and unbeknownst to him, they're raising a grand piano into the 15th floor window of the apartment building above him. And the rope has snapped, and that grand piano is coming careening down on Phil. It smushes Phil, and it's clear that although he felt he was safe, he clearly was not safe. So being safe and feeling safe are not the same thing. Now, on the flip side of it, I want you to imagine I'm in a movie theater, and I'm watching a horror movie. Really intense scene in the horror movie, guy jumps out of a shower with a big knife, I react. My heart's racing, my palms are sweaty, I may be shaking, I'm really, really scared. I feel very unsafe. But in reality, I'm in a big comfortable chair in a big room with lots of other people, and I've got popcorn and a drink. I'm perfectly safe, but I don't feel safe. So that's a key point. Feeling safe and being safe are not the same thing. So in PTSD, traumatic events, almost by their nature, by definition, are surprising and unexpected. So it's normal to try and mull over or think about the traumatic event in order to try and understand what happened better, to be able to use that information in the future. So trying to understand what it means about the safety of the world, what it means about the trustworthiness and compassion of other people. What does it mean about our capacity to take care or protect ourselves? So essentially, it's normal to want to mull over, understand, process what happened in order to use that information to help me to be safe in the future. So I can learn something from it and be safe in the future. The problem is, when I think about the traumatic event, it can bring up a lot of the same feelings that I felt at the time that the traumatic event happened. Feelings of horror, feelings of fear, feelings of shame, feelings of humiliation. So thinking about the event brings up a lot of these emotions, which interferes with me feeling safe in the present. So part of me wants to understand it, to process it, make sense of it in order to use the information to be safe in the future. But by doing so, it interferes with me feeling safe in the present. And that's the big dilemma in PTSD. There's this push and pull between wanting to understand it versus wanting to avoid the feelings that understanding it brings up for me. And so what ends up happening is that people with PTSD will often engage in all sorts of behaviors to try to help themselves feel safe in the present. And these are those avoidance behaviors that we talked about in terms of the second cluster of symptoms. So cognitive avoidance, things like thought suppression, distraction, alcohol use, drug use, changing the subject, trying not to think about the trauma. So I do that in order to help me feel safe in the present. But not thinking about the trauma isn't actually making me any safer. There is no danger. It's not like thinking about the trauma will put me back on the battlefield. It won't put me back in harm's way. It just feels like it does. The behavioral avoidance, so avoiding people, places, activities that remind me of the accident. Realistically, avoiding all men with beards probably isn't going to keep me that much safer just because the person who assaulted me had a beard. But it's something that I do that helps me feel safer in the moment because it helps me to avoid any reminders that bring up memories or thoughts that make me feel unsafe in the present. The problem is the actions don't actually make the person any safer, as I pointed out. And it maintains the person's feeling, maintains the feeling that a person is unsafe or that there is danger in the world. Essentially, the more I behave like I'm in danger or at risk, the more that I'm going to feel that way. The metaphor I'll often use with clients, it's kind of a silly metaphor, but I use the example of the rock that keeps the aliens away. So I have this terrible fear of being abducted by aliens. But one day I come across this rock, and I believe that the rock has a magical power that it keeps aliens away. So every time I leave my house, I make sure that I have that rock with me. And lo and behold, every time I leave my house with the rock, I'm not abducted by aliens. So clearly this rock has magical power to keep aliens away. So just carrying the rock is maintaining my belief and maintaining my fear that there are aliens up there that are going to abduct me. So that's the key, is that as long as I'm behaving like there's danger, I'm going to feel like there's danger. And that's what this avoidance is doing. The more I behave like thinking about the trauma is going to be re-traumatizing or is going to be psychologically harmful to me, I'm going to continue to fear it. I'm going to continue to have anxiety about it. This avoidance also limits a person's life, obviously, in terms of various different types of things we've been talking about in terms of how avoidance behaviors can limit a person's life. So we've talked about one of the things that people will do as a way of coping with PTSD, as a way of coping with these upsetting traumatic memories, is to try to not think about the memories, try and suppress the thoughts, try and push the thoughts out of their mind. And so I want to explain a little bit about how this works. And if any of you were here last year when I talked about generalized anxiety disorder, this slide is going to look familiar. Essentially what I do is I do a little experiment with all my clients about how this thought suppression works. I tell them that I want them for 1 minute to think about anything they want to think about. And usually people will imagine themselves being on some sort of serene, peaceful beach somewhere in the tropics. I tell them, okay, that's great. I want you to think really, really hard about that, really imagine yourself there. And I want you to do that for 1 minute. But in that 1 minute, I want you to try really, really hard not to think about a pink elephant. So I start the clock, and I can tell intently they're focusing on what they're thinking about, and they're imagining themselves on the beach, and then what? Elephant pops up. And they say, okay, they try and push it out of their head. I get them to mark every time the pink elephant comes to their mind, so they put a mark down, and I can see them sort of mentally sort of pushing the elephant out of their head, and then it comes up again and 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 again. Again, it's all they're thinking about. So by the end of that 1 minute, their little piece of paper is covered in marks of all the times they've thought about a pink elephant. So then I ask them, okay, well, in 1 minute of trying not to think about a pink elephant, you thought about it 15 times. How many times in the past week have you thought about a pink elephant? And they'll often say, well, none. Okay, well, how much effort in the past week did you put into not thinking about a pink elephant? Well, none. So in 1 week of putting no effort into not thinking about a pink elephant, you didn't think about it at all. In 1 minute of trying not to think about a pink elephant, you thought about it 15 times. This is the paradox of thought suppression. The more you try not to think about something, the more you end up thinking about it. Now, relating this to that cognitive avoidance in PTSD, the more people try not to think about the trauma, the more they end up thinking about it. The metaphor I like to use is like trying to hold a beach ball underwater. The more effort and force you're pushing the beach ball underwater, the more it's going to pop up. And so it pops up and you grab it and you push it back down again and it just keeps popping up. So one of the things that actually maintains the recurrent intrusive thoughts associated with PTSD is the avoidance. It's trying not to think about the trauma and all the things that you do to try and avoid reminders of the trauma. Avoidance also has another problem in that it gives you fewer opportunities to challenge beliefs and assumptions that may have come up from the trauma. So things like, I'll never be the same again, or people are irresponsible, I can never trust men. So if you avoid, you don't really give yourself any opportunities to challenge or evaluate whether or not these new beliefs that have stemmed from the trauma are actually true. And if you're not getting any disconfirming evidence, you just accept them and continue to behave as if they are true. There's also a problem in that you can't avoid all triggers, no matter how much you try. One of the things that tends to happen with PTSD is the triggers don't just stay the same. They tend to generalize to other areas. I have a client who was involved in a combat situation, horrific scene, there were body parts everywhere, and he had a real difficult time going by butcher shops because just the meat reminded him of some of the things that he saw. So that's not necessarily something that you would realize until you're in that situation. So the triggers will generalize. And so what tends to happen with PTSD is where you feel unsafe tends to get wider and wider and wider and wider. And where you feel safer tends to get smaller and smaller and smaller. So there's no way to avoid the triggers because they will find you. So that's PTSD, some of the symptoms of PTSD. That's the model for at least the model that I use for understanding how PTSD works. I want to talk very briefly here at the end about one of the effective treatments for PTSD. It's something called cognitive behavioral therapy. There's lots of treatments out there for PTSD. Some are effective, some are not so effective, but there are a lot of people doing a lot of things to treat PTSD. The thing I like about cognitive behavioral therapy is that there's lots of research that shows that it actually works, which can't be said for a lot of therapies out there for PTSD. So one of the main components of cognitive behavioral therapy for PTSD is something that if you hadn't heard anything that I've just talked about, and I just presented it to you, you would think this is the most horrific, evil, mean-spirited thing you could ever get somebody to do. And it's something called prolonged imaginal exposure. And essentially what prolonged imaginal exposure is getting the person to write out a script of their trauma in as much gory, horrific, awful detail, including all of the parts of the trauma they don't like thinking about, they don't like talking about, they'd rather forget, and getting them to write that out and putting it into a script where there's no neutralization, there's no anything to take the sting out of it. And then getting them to read that script or listen to that script over and over and over and over and over and over and over again for about an hour every day. The idea behind how this works, the metaphor I use to explain it, is suppose I'm watching TV and there's this weird satellite glitch that happens every once in a while with my TV, and the show that I'm watching disappears, and what comes on the screen is this really gruesome, horrific, awful horror film. And I find it too awful, and I just turn it off. But it keeps happening. Every time I turn on the TV, this horrible horror film comes on, and I keep having to turn it off. Now one day I decide I'm going to watch that horror film all the way through. So I watch it all the way through. It's really gruesome and awful. I feel horrible watching it. But then I force myself to watch it a second time, and a third time, and a fourth time, and a fifth time, and a sixth time, and a seventh time. By the 100th time I've watched that horror film, what do you think my reaction to the film is going to be? I'm probably going to be pretty bored with it. Oh yeah, a guy jumps out of a shower with a big knife and starts stabbing the people. Well, I've seen it before. The film hasn't changed one bit. It's the exact same film that I first saw that 100th time earlier. What's changed is my emotional reaction to it. So you can think about with PTSD, it's almost like the memories of the trauma and the emotions that a person experienced at the trauma become linked. So every time a person thinks about or has a memory of the trauma, it brings up those same emotions. What this process of prolonged imaginal exposure does is it separates the two so that you can have a memory or a thought about the trauma and it doesn't bring up the same level of distress, the same level of emotional distress, same level of anxiety, same level of guilt or shame. And if it's not bringing up those negative emotions, I'm not going to have to work so hard to suppress those thoughts. And if I'm not having to work so hard to suppress those thoughts, the thoughts aren't going to come up as much. So that's the rationale, that's the understanding for prolonged imaginal exposure. And of all the things I get people to do in therapy, it is without a doubt the hardest thing I get people to do. But it's like those commercials for that Buckley's cough syrup, tastes awful, but it works. It's the same with this type of thing. It's really, really, really difficult to do, but it works. It helps a person process the trauma, be able to separate the emotion from the memory, and then be able to have the memory without the emotional experience, or at least the same level or intensity of the emotional experience. So that's prolonged imaginal exposure. And by the way, a lot of therapists don't like using prolonged imaginal exposure. It's about 80% of therapists and psychologists who treat PTSD do not use any form of exposure-based therapy. In part for fear of traumatizing their clients, in part because it's not very nice to experience, but it works. Second component of cognitive behavioral therapy, I usually use this while we're doing the prolonged imaginal exposure, is what I call challenging stuck points. Essentially identifying and challenging the negative maladaptive beliefs or assumptions that a person develops from the trauma. So things like, I could have done more. I should have fought him off harder. Or the car was on fire. I thought it was going to explode. I'm a dirty, awful person. So these are examples of beliefs that people will have following traumatic events. The first one in particular is one that comes up a lot I find for my clients who are sexual assault victims. The one thing to point out is the assumption is that what I would have done or the other thing I could have done would have been more successful. I could have fought him off and I would have been successful. You don't know that. The reality is, clients in my office because they're alive. So whatever they did ensured that they stayed alive. Whereas had you fought off harder, maybe the person would have got even more violent, even more aggressive, and maybe you would have been killed. So that's one of the assumptions we always challenge is people always assume that the other things they could have done would have been more successful. But how do you know? There's also the issue of secondary wounding, which is essentially things that happen after the trauma that contribute to the suffering that a person experiences. So for example, I used the example earlier of the friends that think it's funny to sort of scare somebody who has an exaggerated startle response. And so it'd be really easy to think, well, my friends don't care about me, my friends are insensitive, my friends are just jerks. Well, that's one way of viewing it. Another way of viewing it is that maybe they don't get it. Maybe they think it's funny because they don't understand it. Not that they're doing it because they want to hurt you or they're doing it because they know it's going to really bother you. So addressing some of those issues around secondary wounding in terms of the way people are responding to you and what that means about them, their intentions, that kind of thing. And a third component of therapy is behavioral exposure. So this is essentially coming up with a list of all of the situations, places, activities, things that you avoid, and rank order them from easiest to hardest, and essentially start working through the list. And as you go along, I put up there suppression of safety behaviors. There's lots of things that people will do to try to help themselves feel safer, but don't actually make them any safer. Like if I'm going to be crossing the street, I need to have 3 people with me, and I only cross in big hordes of people. Okay, well maybe that's where you'll start. But as we go along, then maybe you take on sort of maybe less busy streets, but with fewer people around you. And then you cross the street by yourself at a really quiet intersection. Then you cross the street at a more busy intersection by yourself. So identifying those safety behaviors and using them as part of the exposure hierarchy and gradually removing them as you work your way up. So the good news is this type of therapy works. There's a lot of research that shows that this type of exposure-based therapy is more effective than supportive therapy. A lot of research has shown that people can get relief and benefit in as little as 15 hours of therapy. Obviously, it depends on the nature of the trauma and the number of traumas that a person's been exposed to. But the gains are maintained. So research studies have shown that 6 to 18 months after the end of therapy, people are maintaining the gains. So the therapy is really about teaching a person skills, and as they continue to use the skills, they continue to experience the benefits from it. So like I said, this is just one form of therapy. It's what I do. It's obviously my bias is to think it's great because it works, and there's lots of research to show it works. There's lots of other different types of therapies, and there will be a lot of therapists, a lot of psychologists that would say, no, what you're doing isn't as good as what I'm doing. But that's just the nature of psychology. We tend to disagree, but this is what I think works. In terms of resources, there's a few resources here on the slide. If you're interested in learning more about PTSD, you can go onto my website. On my website, there's a resource library. There is a page on PTSD. There's lots of information that you can download for free, also links to videos. The North Shore Stress and Anxiety Clinic website has a resource list with books on it in the adult section, and there's some books on PTSD. If you're interested at all in anxiety, the Anxiety BC website is, in my view, one of the best websites on the internet for information about anxiety. They have a page on PTSD. It's exceptional stuff, so I highly recommend the Anxiety BC website for anything anxiety related. The slides from this talk, I'll be getting them up on the clinic website, and they'll be up there for 2 weeks, just in case any of you haven't taken notes and want the slides. And as Ken pointed out, this is, I guess, now the 5th talk that we've done. We want to do more. We also want to do talks that people are interested in. The way this talk came about was I did a talk on generalized anxiety disorder last year, and after the talk I was approached by 3 or 4 people who were asking questions about PTSD. And so that's how we got the idea to do this talk. If there's any talks that you're interested in, that you would like to know about or would like to let us know you'd be interested in hearing about, we've got lots of psychologists with lots of expertise. You can just email me. No guarantee that we'll be able to do it, but it's always nice to know what people are interested in learning about. So that's all I have for tonight. Thank you for your attention, and I guess we'll open it up for questions.